Okay, so hopefully everyone can see the slides now. I hope it's okay, but I can't seem to be able to see the chat function at the same time. So if there are any questions, can you just let me know? Otherwise, I'll just go through them at the end. So, like we said, my name is Dr. Lasker, or Imran Lasker. Just call me Imran, it's easier. I'm a consultant radiologist, and I've been a consultant for 5 years, which is crazy to think about how quickly time flies by. But I've been asked today to go through shoulder X-rays and basic interpretation of some of the common pathologies that can come up to try and help you through exams and actually in life in general when you're running around looking at X-rays on the wards and that kind of thing. So this is actually particularly useful if you are on A&E and that kind of thing as well, because you're going to get lots of people who've fallen over, hurt the shoulder, and potentially fracture themselves and stuff like that. So X-rays are very, very common. Obviously, chest X-rays are the most common thing to happen in an A&E environment, but shoulder X-rays are very, very common. The mobility of the shoulder means it's more prone to injuries. If you think about it, your shoulder can go all the way backwards, all the way up, and all the way around. You can't really do that with your hips because the hip is kind of a more pincer-like joint, whereas the shoulder is less like that. It's got a lot of mobility, but when it's got so much mobility, it can also dislocate and also more prone to injury. Also, we are using our arms a lot, playing sports, lifting things, throwing things, and all that kind of thing. So you can imagine the shoulder joint, the arms, the hands, those are usually what gets injured when injuries happen playing sports and that kind of thing. So let's just get acquainted to some of the views that exist when you're looking at X-rays. So there are three main views. You're going to have your AP view, you're going to have your axial view, and then you're also going to have your sort of axillary view as well. And it's just important to sort of orientate yourself with the anatomy of what you're looking at and what you're actually looking for when you're looking at these images, because it's very important to know that these things are done for a reason, right? There is a reason for doing these particular views, and each kind of view will give you a little bit of information. Now, what I'd kind of implore you guys not to do is to call anything grossly abnormal on one view. Like if you only got one view, then you really should ask for three views, because remember, these are 2D representations of 3D people, right? So 3D people walking around, you got 2D image. So at this point in time, this may look like it's all okay and you move on, but if you have a different view, you may notice that something is slightly abnormal. Also, when you're looking at different views, you have a little bit of overlap. So there's structures that overlap with one another, and they're a little bit more difficult to see on some views compared to others. So we're going to go through some of the basic anatomy first. So this is the humeral head, right? And then you've got something called the greater tuberosity and your lesser tuberosity. But mainly you want to be concentrating about the humeral head. You've got your neck of the humerus, and then you've got your shaft of the humerus. It goes all the way down like so, right? And one of the main things to do at the very, very basic level is just to sort of draw along the line and just make sure that everything aligns really, really nicely all along like so. If you find any dips or anything like that, then you've got to start worrying there could be some kind of fracture. Obviously, fractures can be very, very subtle, and so you have to try and be able to attune yourself with what a fracture actually looks like, and I will go through that as we go through the rest of this talk. But one thing I want to draw your attention to is when you look at the edges of any bones, right? So when you look at the edge of the bone, you can see that oops, sorry, let's go back again. When you look at the edges of the bones, it becomes very, very sclerotic as you get to the edge. And sclerotic means it gets very, very white in appearance. So look at the bone, and as you come look at the central area, it looks very sort of blackish, and as you get to the edges, look very, very white, and gets whiter and whiter at the edges. And that's kind of normal structure. If you're thinking that something's a fracture, but you can see it getting more and more sclerotic, more and more white as you get to the edges, then you're not looking at fracture, you're probably looking at a normal structure. And these can be vessels, grooves, all sorts of things. So for example, this one, you can say, oh, that could be a fracture. But when you really take a look at that, you can see it does get a little bit sclerotic as you get to the edge of that line, and then another line appears. So this can't be a fracture. Fractures are something that's introduced brand new to the person, and then they end up getting a big fracture, and then it kind of looks very, very black and no kind of transition. It's just a black line in the middle of everything, really. And again, I'll show you as time goes on what that really looks like. So we've looked at the humeral head. So that's the humeral head. And what you want to do is make sure it aligns nicely with the glenoid. Now think about the humeral head and the glenoid, like I said before, with regards to the hip versus the shoulder, is that the hip is like a really pincer sort of joint. What I mean by that, you've got your femoral head, which is your leg, and it goes into the acetabulum, which is the ball socket, and it really kind of covers the whole thing right around like this. It's very, very hard to dislocate. You need a really big impact to do that. But as you can see, this doesn't really feel like a hip joint because it doesn't go all the way around like so, it doesn't go all the way around like so. It kind of just sort of sticks around about this far and doesn't go any further. So that makes it slightly unstable, actually. And what we'll often say in radiology teaching anyway is try and imagine it being like a golf tee. So you imagine that this is kind of a little tee and you've got your golf ball sitting on there like so, which means it can swivel around a lot. This can kind of move around, and that is good and bad. Because good, that means you can reach all the way around the back, you can kind of scratch your back, you can do all sorts of things. But the instability means that you've got to have other structures to try and keep it in place. So you do have this sort of cup-like structure called a glenoid, or fibrocartilaginous glenoid. That's a bit more advanced, but there's a little bit of a suction cup there. And then you've also got tendons that go all the way around and hold things in place. You've got your supraspinatus, your infraspinatus, and your subscapularis. Often you'll find that sports people talk about, oh, they've got a rotator cuff injury, they've got a rotator cuff injury, which is entirely possible. But the rotator cuff essentially is these tendons that hold everything in place, and it kind of gives you a balance. Now, what can happen is that sometimes some sports and some sportsmen or women and bodybuilders, they can sort of overdevelop certain muscles, and that can mean that their shoulders are a little bit more unstable than others. And that can result in easier to dislocate shoulder joints than the average population. So these are where your tendon would go, right? Tendon would go all the way around like so. Another one go around there. Another one goes around the back and around the back of the scapula. And that will make more sense as we go through the rest of the study, rest of the cases. Next bit to know about is the acromioclavicular joint. Don't know why that's popped up. That's the acromioclavicular joint. Now you can imagine, I mean, maybe you've seen it, that some people have actually got fractured clavicle. Sometimes that clavicle becomes dislodged. You get dislocation of the clavicle, and you get stages of dislocation. And the way to really look at this is to kind of draw a line all the way along like so, all the way underneath, and make sure everything nicely aligns. Now there are ligaments that go all the way from here to here, from here to here, from this thing called the coracoid process. Main thing is you do have ligaments that hold things in place. Sometimes you'll see like some bits of bone that pulled off, and this is just flying around in the wind because this is just not being held in place. The next thing is going to be the shoulder blade. That's this thing all the way around like so. Now the thing about the shoulder blade is, what I've noticed is that sometimes people will see this line and think, oh my God, they've got a pneumothorax. And a pneumothorax, for those that don't know, is a popped lung. But I always encourage people to try and draw. If you see a line that looks a bit abnormal, draw a line all the way around, all the way around, all the way around, and just really follow around and see where it goes to. And you can see that this goes from the lung to outside the body and then follows the scapula all the way around like so. So this is definitely the scapular blade. So just be aware that you can get a bit of overshadowing or undershadowing from the scapular blade on the chest images as well, and you'll be able to see the scapular blade on chest x-ray. So please don't stick a needle into the patient. Try and draw the lines all the way around. The other thing to remember is you also got ribs, right? And that's important because often with trauma, someone comes in, they've busted their shoulder, say, oh, I've really hurt my shoulder. And people are like, oh, wow, okay, great. You've got fracture, but they don't notice the rib fractures. And this is one of the things that we always say in radiology is that the most commonly missed fracture is the second fracture, because everyone gets so fixated on the one thing that they've seen that they forget that the other things that are on the picture. And these are 3D people, right? So if someone gets a massive impact over on this side, then they're also going to be likely to have an impact here. So there could be a scapular fracture, a rib fracture, there could be pop lung, there could be all sorts of things that happen along with the initial fracture that you've seen. So always find the fracture, then move on to the next one. So what's this AP view that we're looking at, and why is it useful? The AP view is very, very good at looking at the acromioclavicular junction, making sure that everything's nicely aligned, looking at the alignment of the glenohumeral joint, and also looking at the ribs as well. That's where I think is very, very good, but you need the other views to really supplement what's going on and see what's happening. So now you're looking at lateral view. So lateral view is kind of, you're looking from the side like so, and you're looking at the scapula, and you've got to try and draw this out, and they actually call it a Y view. And the reason why they call it a Y view is because when you draw that scapula, it looks like a Y. And then why would you do that? Is to try and make sure that you can see the alignment of the humeral head, which is this. And you want to make sure it kind of either sits right bullseye in the middle of this Y, or you want to make sure that the humeral head is facing towards that Y, because sometimes you don't get quite a lateral view. You know, patients aren't perfect. They move in the middle of the scan. They don't quite stay still. You don't get a perfect image. So sometimes you see the humeral head sitting like this, but it's still overlapping slightly or pointing towards that sort of center X, right, or center of that Y. Very, very important, because if it's gone forward or backward, then you'll know from this particular view. It's very, very good for looking for anterior or posterior dislocations. Also quite good for looking at sort of the lateral aspects of the ribs, because as you can imagine, when you're looking straight on, because the ribs are like a curvilinear thing, you can sometimes miss fractures. So sometimes having a slight angle on things can be very useful for looking at rib fractures. And again, you've got your clavicle, you've got your cromoclavicular joint. And if you're worried about which one's anterior and posterior shoulder, there's something called the coracoid process, which is what I showed you earlier, which is this guy here that attaches to the clavicle with some ligaments. Well, that's going to be the most anterior part of the body, and that it looks like a little ball. So this looks like a bit of a ball, whereas this looks like a bit of a flat T over here. So this is going to be the most anterior aspect of the shoulder. Okay, good. So then you've got your axillary view. And again, this is really, really useful to try and look for dislocations. And this is where you get a proper golf tee appearance to the shoulder. So I'm going to show that to you. So you've got your scapula going like this. You've got your kind of glenoid, and then you've got your golf tee. And then you've got your golf ball that's sitting right over here. And as you can imagine, if this has gone forwards or backwards, you will see that. The most anterior aspect of the shoulder is going to be the coracoid process. So that's that. So this is going to be the forward bit. And then everything else is going to be posterior, because this looks like the kind of more flattish T of the scapula. The axillary view is very, very useful. And I'd obviously highly, highly recommend that you use a combination of all three things to try and identify whether something is adequately positioned when you're looking at a shoulder X-ray. So there is a framework that has been suggested, not something I use anymore, but frameworks are very, very useful for when you actually start doing any sort of imaging. And this is quite a good one. I quite like it. ABC, a bit like your airway, breathing, circulation. But actually this can be to do with alignment. Look at the bones, look at the cartilage, and look at the soft tissues. Now, soft tissues are often ignored when you're looking at chest X-rays. And I think it's very, very important, because that can actually give you a clue as to what's actually happening with the underlying structures. So sometimes all you see is a whole load of soft tissue swelling. You have a closer look, and then you find the abnormalities. It's very, very important to identify soft tissues. It's all very well me saying that, look at soft tissues on the X-ray, but what does soft tissue look like on an X-ray in the first place? So this is where I always say, try and go back to basics. When you're looking at an X-ray, first of all, just think to yourself, okay, do I know what bone looks like? Do I know what air looks like? And do I know what soft tissue look like? So bone and air, we should really know, right? So outside the body is going to be air. We know that because nothing else is going to be around the body. So this must be air. So anything that's kind of blackish or close to black is going to be air. Anything that looks like this is going to be bone or very, very dense. And anything between the two is going to be soft tissue. So all this is going to be soft tissue. That's going to be some of the muscle. That's going to be axilla. And that's going to be a bit more axilla, supraclavicular region, a bit more supraclavicular region over there. But then you'll say to me, hang on, Imran, hang on. You said black, right? So black is air. What's that? Because you've got a bit of muscle, you've got a bit of blackness, and you've got a bit of muscle here, or whatever soft tissue located here. And remember, you've got to try and remember that X-rays are a representation of A, 3D structures, and B, densities, right? The more dense something is, the more white is going to look on an X-ray. The less dense it is, it's going to be more black. Now, air is not very dense, but the other thing that the human body can have that's not very dense is fat. So fat can be very, very low density. And in between musculature, you have fat planes, and fat planes can look very, very sort of black. And sometimes you get to see some of the fat planes that exist located between the musculature as well. So that's so when you're looking at alignment is what I told you. Checking, sorry about that, let's do this. So checking the alignment is to look at the humeral head and the glenoid and make sure they're nicely aligned. Looking at the bones, you just got to make sure the bones look okay. And the way I do is I genuinely draw around all the way through, all the way around, all the way around, all the way around, all the way around. And I keep looking for any jagged edges or anything like that. Keep looking, and I draw around every single rib. Now these are the posterior ribs, and it go curve around and become anterior rib. Posterior, lateral, anterior. And you do that all the way down, all the way down, all the way down. Make sure you can see every single rib. You can see the clavicle going along like so. You can see the soft tissues all around it. So you've done your bone. Cartilage is a little bit difficult. You can't see cartilage on an X-ray, but you can kind of infer it from the alignment of the humerus and how close the humerus is to the glenoid. And I think there'll be an X-ray coming up later. And soft tissues, like I said, let's say this is going to be your trapezius muscle. And if it suddenly looks like really bulgy, then you know something's up. If you see this really bulgy, you know something's up. If you see something like this bulging up like this, you know something's up. So it's just important to try and identify what soft tissue looks like, and does everything look nicely aligned with soft tissue. So key structures I've already talked about, but as you'll notice, I'm going to keep talking about again and again and again so that you guys get used to it, right? So humeral head, where is it? Humeral head is sitting over here, right? Then you've got your greater tuberosity and your lesser tuberosity. Now, the greater tuberosity is quite important because this can get fractured, because when you get dislocation, sometimes this hits the top and gets a big fracture. Sometimes when you get proper big dislocations, if it goes anteriorly, this little edge over here goes and hits this edge over here, and you get big fractures there and there. So both areas can get fractured. And also just medial, or so medial is kind of towards the sort of middle or the medial sort of center of the body. You've also got a bicipital groove as well. So that's quite important when you're looking at MRI. But that's a greater tuberosity, very, very important landmark. This is the glenoid, and very important to know what the glenoid looks like. It's a kind of suction cup, a bit of bone, a bit of cartilage there to try and hold things in place. And then you've got your acromioclavicular joint over here. You want to make sure that all aligns quite nicely. This is your clavicle. And you've got your coracoid process. So the clavicle is held in place by ligaments going along this way, along this way. It's called the conoid and the trapezoid ligaments. You might need to look that up, but I'm pretty sure that's what it's called. And around here, so you've got subacromial space. So what does that mean? You can either call it your subacromial space or your subdeltoid. So your deltoid muscle, for those that are into bodybuilding, are the things that people do lateral raises for, and they get really, really big. But underneath the deltoid muscle, you get a bit of fluid just to keep things kind of flowing over one another, and that can get inflamed. When you call it subacromial space, essentially the same thing. That's your acromion, and then you can get fluid just underneath it. Sub means submarine, so sub below, acromion, subdeltoid, below the deltoid, same thing. Subacromial, subdeltoid space, the same thing. It means there's fluid underneath those areas, but above the rotator cuff. So the rotator cuff muscles are here, tendons and muscles over here. Then you've got your subdeltoid fluid or acromial fluid, and then you've got your deltoid muscle. So that's important because when you do interventions like injections, you don't go all the way through. And this is where I find it really baffling sometimes, actually, when you find out that, like, I don't hate on anyone, yeah, so don't take this the wrong way, but you'll find out some GP or an orthopod has gone and done a needle injection to the shoulder, and they've said, oh, put it into this subdeltoid space. But when you look at that space under ultrasound, it is literally the thinnest space. I don't know how they do it. I don't know how to do it, but without ultrasound, I don't see how you can do that accurately. Right. So let's have a look at a few pathologies that exist when you are looking at the shoulder. So this has given the answer, but we've had a look at, so what I also will do is try and encourage you to have a bank of normal, right? And if you're never unsure, go to Google, type in normal looking shoulder, and then compare it to the person that you've got in front of you, right? So obviously you've got your experience of seeing the patient in front of you. They've gone and said they can't move the shoulder. You look at the contours and one looks a bit dipped compared to the other. Something doesn't look quite right. And so then you've got to try and look at the x-ray and try and figure out what's actually happening. Now, actually, there was one situation where we had this guy come in, and I think they didn't notice, but he actually had bilateral shoulder dislocations because he felt fallen down a manhole. And they hadn't noticed. He said he had shoulder pain, but he's really new. Like I think he was very, very drunk. He wasn't really making much sense. But because people would try and use symmetry and all that kind of thing, because they were both dislocated, then they actually noticed the next morning that he couldn't move his arms. And then, yeah, they had to look at the x-rays and realize, yeah, he dislocated both shoulders. So for this one, we've only got one view at the moment, but I think from this view, you can pretty much be accurate as to what's going on. You've got your humeral head, which is over here, and that's your glenoid. So they're very, very far apart from one another, right? They look really, really far. And then because it's got inferiorly, you can sort of infer it's probably got anterior and inferiorly. And you can also see why the inferior aspect of the glenoid is probably going to hit the superior lateral aspect of the humeral head. When it hits the superior aspect of the humeral head, that's going to be called a Hill-Sachs defect, and that's going to be called a Bankart lesion. Now, if you're ever confused, and you ever hear that phrase, and you think, oh, what does that remember? What does that mean again? If anyone says Hill-Sachs defect, remember Hill starts with the letter H, and therefore it's going to be a humeral head problem. So Hill-Sachs defect is going to be over here, and then the other one, which is the Bankart lesion, is going to be right over here under the anti-inferior aspect of the glenoid. These two impact. So sometimes it'll relocate by itself, and you think, oh, it's fine, mate, you don't, no worries. But actually, when you look at the x-rays, a massive dent sitting there, and sometimes you even got a fracture there. So it's very, very important to be aware of those two structures when you're looking at dislocations, because even when it's gone back to normal, you can still see signs of the previous fracture. The other reason why this is important is because if you do have fractures in those particular areas, it means that you can be more predisposed to getting anterior dislocations in the future. So what you'll find sometimes is people come in and say, yeah, this is not the first time. This is not my first, no, it's not my first rodeo or something like that. So it basically means that they've got an instability to the shoulder, and it's not always a bony instability. So do you remember when I said that you can get the sort of cartilage stuff? That's called the fibrocartilaginous glenoid. Sometimes that's injured, and that results in this instability. And so bony reasons, it looks completely fine, but they're saying it's very unstable. It kind of comes out, pops out, and goes back in by itself. And sometimes you get proper fractures, like this bone is completely gone. Sometimes it's moved away. You've got big dent sitting over here, and that makes it very, very unstable. And what they actually need to do is go back, get that fragment, just nail it into place. You see the little nails going into there like that. And I don't think they do too much with regards to the Hill-Sachs injury. But it's also important to remember that when you get someone who's got that many Hill-Sachs injuries or that many fractures and that kind of thing, then they may end up having rotator cuff injuries as well. So these are the ligaments that go. These are the ligaments that go all the way around and hold everything in place. There may be a bit of instability issues as well as a result of problems like I was talking about. So then you get the opposite problem, which is going to be the posterior dislocation. Now, the posterior dislocation is a little bit more difficult to really identify on an X-ray, but the history can help, because if they've got seizures or they've got electrical injuries, things like that, or really significant trauma, that can result in a posterior dislocation. Most of the time it's going to be an anterior dislocation, but occasionally you get a posterior dislocation, but most times it's going to be anterior. Now, if we go back to this, you'll see this looks like a bit of a hook, like a staff. Sorry, I got a bit of a cold. This one, it kind of doesn't look like that. It looks like a light bulb. It doesn't have that kind of walking stick appearance. It's kind of got this lighthouse appearance or light bulb appearance. When it looks like a light bulb, then you've got to start to think, okay, this could be a posterior dislocation. Now, on this particular image is not the easiest one to see, because your glenoid is here, and then your humeral head does look like it could, you could fool yourself into thinking that actually it's all right. And that's when it's very useful to have that Y view or the armpit view, the axial view, to try and see whether things are really aligned with one another. And do you remember when I was saying, how do you know which was posterior and anterior? That coracoid process is going to tell you what's anterior. So if it's gone posterior to that, then you know it's a posterior dislocation. If it's gone anterior to that, or the same direction to that, then you think it's anterior dislocation. But based on this view, on first instance, you've got to go with this being a kind of light bulb appearance, and therefore going to be most likely be in keeping with a posterior dislocation. And so that, yeah, like I said, this can be more important to understand that this has a slightly different view, but also going to have slightly different secondary injuries. Now, with the previous one, you had a Hill-Sachs defect over here, and you got an injury over here. But when you go to the posterior dislocation, you're going to have something called a reverse Hill-Sachs injury, and you're also going to have a reverse bony Bankart injury as well. Okay, so let's have, I think a question has come up. I'm just going to have a look at it. Give me a second. I don't understand how you'd get a posterior dislocation with a seizure. Normally, patients fall and seize on their back, so they wouldn't hear the humeral pop out forwards. Yeah, so you are not incorrect. Of course, you're not incorrect. But it's one of those things where you're talking about chicken or the egg, right? So what came first? So yes, in that particular instance, someone could have a seizure, fall over, hit the humeral head, and then it fall back, and then it goes backward, goes anteriorly. That would still make it a traumatic injury, because you're talking about the thing that caused the injury was a seizure, but the seizure itself did not cause the dislocation. But if you've got a seizure where you've got abnormal twitching and flexing of the muscles, same thing with electric injury, the seizure itself is the cause of the dislocation, not the trauma that may have followed it. Does that make sense? So yeah, traumatic wise, it's going to be an anterior dislocation, like most of the time, like someone playing rugby trying to do a tackle, which is actually what happened to me, or they're bench pressing, or what's the other one? The pec neck is the one that does my shoulder. So yeah, there'll be things, or they're mechanical causes. But when you get someone who's getting these kind of really tensing episodes, where everything's kind of firing at very different times and very, very harsh sort of contractions, then that's going to be the thing that caused the fracture in the first place. I hope that makes sense. If it doesn't, then I can try and go through that again. But your situation here is like, it's one of those things where I get, because I do radiology, I get all sorts of stories. And I'm not saying they're not true, of course, they're true. But sometimes someone will say like, oh, someone's had a bleed. No, they've had like a stroke, and they've also had trauma. So what caused what? And it's sometimes hard to know what caused what, because a bleed can cause them to fall over and hit the head and end up having a stroke. have like a traumatic injury, but also like having a traumatic injury can also result in a stroke because of the mechanism of injury. So sometimes you're not sure what happened like first, and that's the thing with it. With this particular situation you're talking about, yeah, the seizure and the stuff is not what caused the dislocation in the first place. Right. So now we're moving on to clavicle fractures. I don't think this is the most obvious fracture that we can see, but you can see that there is a bit of a linear abnormality located here and a bit of an overlap with respect to the clavicle. And the thing is, I don't think this person this is the first injury they've had with regards to the clavicle, because if you look at the clavicle, you can see there's this kind of linear densities located here, and they're far too dense to be bone. Like if you look at the bone there, that's far too dense to be bone. And I suspect what's happened here is that this is not the first time they've had a fracture. What's ended up happening is that they probably had an injury in the before, which has resulted in ligamentous injuries. Remember I told you about the trapezium and the conoid, trapezium and conoid ligaments. Sometimes they get injured. And so what they do is get these clips and put it back into place and get everything back in place. And actually, if you look, I reckon there could be a circular thing over there with a dot, and that kind of loop around like this and holding everything in place. But I think there's going to be a ligament injury, but they may have had a clavicular fracture as well. Now, what you'll find when you are doing these traumatic injuries, most of the time it's going to be the middle third of the clavicle that's fractured, not the medial third and not the lateral third. Usually it's the middle third, because that's usually where someone gets a direct traumatic problem. It had to be quite a hefty injury to get a fracture of the sternoclavicular joint, unusual injury to get in the acromioclavicular joint. What they generally say is that when you get injuries around here and here, there's going to be a concurrent abnormality. It's either going to be rheumatoid arthritis, inflammatory arthrosis, osteoarthritis that can cause that. And again, because, yeah, I mean, I talked a lot of bodybuilding and stuff. So what can also happen is that when people are doing a lot of bodybuilding or repetitive movements, you can actually get osteolysis of that distal clavicle. So that can get really, really shortened over time as well. So generally speaking, when you're looking at trauma, it's going to be the middle third. So if you split it to 1, 2, 3, it's going to be this area here that's going to be that's going to have the fracture. Like I said, mid shaft or middle third, it doesn't matter. It's going to be one of those two. Generally speaking, do you do much of it? Not always. You don't always do surgery. Sometimes you'll meet people who've just got like a massive bump there and they don't care. It doesn't really affect their movement or that kind of thing. In fact, I think I saw a video once where it showed that Samuel L. Jackson had a mid-clavicular fracture, showed it in the interview, and it didn't look great. Anyway, rotator cuff. So this is what I was talking about with regards to in the spaces. You've got your rotator cuffs. You've got tendon that goes around like so. You've got tendon that goes around the back, and the tendon that go around the front. But let's say you've got missing tendon, and that results in instability of the shoulder anyway. Then you can start to get something called subluxation of the humeral head towards the top over here. Now there's nothing sitting over here. That's all gone because the tendon's ripped and pulled away along that. So you got this touching this area, and you get osteoarthritis and this subacromial area and the humeral head as well. And you can see this is not nicely lined at all anymore, right? Now, one of the questions people have is, well, hang on, if you've gone and ripped your rotator cuff, how can you still move your arm? Now, what people underestimate is actually your deltoid gives a lot of movement to your shoulder. So your shoulder is moved a lot by your deltoid, and the sort of finer movements are really given by the rotator cuff. And your rotator cuff gives a lot of stability to your shoulder. So sometimes you'll actually see that someone's got a complete rotator cuff tear, but they're still able to use a lot of function from their shoulder because the deltoid has given them a lot of the movement that they require to be able to do the things they want to do. So despite the fact that the person may not have a supraspinatus at all, they may still have a fair bit of good movement with regards to their shoulder. I genuinely, when I don't do so much ultrasound these days, but I used to get patients come in and then I would get them into positions to be able to do the shoulder ultrasound. They'd do it, but there wouldn't be very much tendon there. That's because the other shoulder muscle, or the big one, has really taken over a lot of their movements. But like this says, what you can have is a bit of chronic shoulder pain. And as you can imagine, it's not the most stable of joints. And so a little bit of movement here and there can result in osteoarthritis. And as you can see, there's clearly some osteoarthritis here. That can result in a cascade of abnormalities, right? Because you've got that fluid burst that I was talking about earlier. You can then end up getting inflammation or subdeltoid bursitis. You get more calcifications that can result in impingement and resulting in lack of movement. They may find they can't really lift their shoulder as much as they'd like to. Yeah, there's a whole load of things that can happen as a result of this over time. And sometimes you don't even do surgery because the person that you're looking after, they're quite unwell anyway, or they're kind of a bit more elderly. It's going to be risky because all surgery is risky. Right, there are a few red flags to think about. When I say red flags, and actually this is more with clinical examination, right? And one of the clinical things that you'll see is something called open fractures, right? And I hate, I wasn't someone who liked blood very much, right? So you can imagine how I felt when I saw open fractures. But when you got a literal piece of bone just sticking out the body, you think, oh God. And that's terrible because the outside, basically the inside should not really communicate with the outside at any point, right? But when you get communication like this, it means that you can get bugs and all sorts of things hitting this area because now it's exposed. Maybe they motorcycle accident, they've gone and scraped on the gravel and a whole lot of muck is in there. The problem here becomes the fact that bone's blood supply isn't all that good. So if you go and get an infection here and get some osteomyelitis, then getting rid of that infection is a complete pain. That is really a lot of work and a lot of long-term antibiotics, which then can result in longer-term problems later on down the line. Yeah, these things are not great when you get open fractures. Now, one thing I just want to show you again, remember how I said it gets very sclerotic as you get to edges of normal bone? This one you can see there's no whiteness at all to the edges. So this is complete fractures, right? And that it's a fracture because first off, you can see it's not lined anymore. And you can also see that there's a complete sudden transition from normal bone to complete nothingness. And I wonder whether they probably had some ligamentous injury here because that doesn't quite align anymore. It's kind of veered off to that way. But the acromioclavicular joint is still in line. So there may be a ligamentous injury. So they may need to pull that back in place. You get like a metal plate fixed screw fixation there. They may get some ligament and or they get this rope stuff to try and pull it back into place as well to get everything nicely lined again. Also, just make sure when you get these big traumatic injuries, have a look and make sure there's no rib fractures anywhere else. Because remember, someone's been hit quite hard there. They're going to fracture their clavicle. You've got to look at everything else. You've got to make sure there's no pneumothorax, anything else more concerning with this patient. So this is our young person. By the way, they're young because they've got growth plate. Growth plates look like this. And like I said, don't get worried. Don't think, oh my God, they've got a massive fracture. Have a look at the edge. Go all the way to the edge, go all the way to the edge. You can see it looks very, very sclerotic as you get to the edge, get to the edge, get to the edge. If it wasn't and looked very, very linear and abrupt, then you think, okay, I think this person's got a fracture. But when it looks like this, then you've got to think to yourself, okay, that's probably a growth plate and this is a younger person. But you can see that this doesn't look quite right. It doesn't look like that sort of shepherd's staff or hockey stick or whatever you want to call it. It doesn't look like that. It looks like a light bulb. Therefore, be more concerning for a posterior dislocation. Now, the space that you have, this one looks like it could be a chronic fracture or impact fracture because it doesn't have that sort of smooth appearance. And it kind of impacts, right? It looks like it's shortened. And you can also see that the line does this and kind of suddenly becomes like that and then comes around. Line does this and comes around like this. And you've got this almost linear line like so. Now, these can be chronic, can be hard to tell on this one because you can't see a proper radiolucent line going along like so. It may be an impacted fracture. But one of the things you may notice that you've got your clenehumeral joint that's over here, but this is all the way over here. So this could be an anterior dislocation. But sometimes the trauma is quite bad and you've actually got a bit of fluid that builds up over here and then pushes everything down. Now, the reason why I think this is going to be more likely to be a joint effusion rather than anything else is because in the human body, you should not have straight lines at any point, right? But when you look at this has got a straight line that goes all the way across like so. So that must mean it's like a fluid level, right? And that can happen because there's blood or there's fat or there's fluid. And what you can see is a fluid line like so, and you've got everything being pushed down like so. So therefore, this must be an effusion as pushing things down, making this sublux, and there's probably going to be a fracture as well. Now, fractures can be, so you've got like a joint capsule that goes like this. So sometimes you get like a fracture that's inside the joint capsule, and then you get a whole lot of blood and pus seeping out to the joint. But it's outside the joint capsule, you may not have such an obvious subluxation like you see here. Okay, so this was, so if we look at this one, it's the same patient we saw a bit earlier. 40-year-old male presented with shoulder pain after a fall on an outstretched hand. And this is the kind of thing you see in the movie. Someone's going to dislocate the shoulder, they'll hold on to something and pull really hard and pulls it back in place. I don't know if it's too old to film now, but it happened in Blade. I think he did it. He held onto they're on the crane and he pulls the shoulder back in place and you hear a crack. You can do it. You can self-manipulate it in place if you've got a pain threshold like blade, but the average Joe probably does need to go to hospital and get that put back in place on gas and air and all the rest of it. But you can see that's a humeral head sitting like so. It's very, very anterior. You can see the edge of the anterior inferior aspect of the glenoid. You can see the edge over here as well. This may impact with here, and therefore end up with a bone contusion or an injury or even a fracture. Very, very important to see that this area doesn't look like it's fractured and fallen away, because that can result in instability later. Yeah, this can be quite a significant injury. And then sometimes you get really nice x-rays where it looks like this. Post manipulation, it looks normal again, and everyone's happy, patient's happy, orthopods are happy, everyone's happy. So I think we've answered these. On this particular x-ray, we can see that the shoulder is anterior dislocated. This can be most likely keeping with anterior dislocation, and you manage the patient by gas and air and manipulation. Okay, let's have a look at this one, and I'm going to get you guys. So yeah, manipulation, reduction under sedation, immobilization, follow-up with physiotherapy. Yeah, so what with physiotherapy, remember I said about the rotator cuff muscles. So sometimes with physiotherapy, it can be very, very useful to try and get the muscles and tendons to be a bit stronger. You do all these kind of rotator cuffing like exercises to try and get things back into play with one another after the bruising and all that rest of it. Okay, let's have a look at this one and get you guys to think about this. I don't have access to the chat as far as I can see, which is a bit weird for this thing. Let me see if I can grab it. No, oh no, I can. Okay, maybe that does work. So let's have a look at this one and think about what we can see. Some of you guys may have seen it straight away. Feel free to throw in an answer onto the chat. If not, don't worry, I'm going to go through it. 55-year-old female presents to the emergency department after slipping and falling directly onto her shoulder, reports significant pain and difficulty moving her arm. Okay, so this is going to be the humeral head, and it does feel like it's not quite aligned, but you do see a fair bit of overlap, so maybe that's okay. I would want to see the axial and the sagittal views and the rest of it to try and make sure. You got your clavicle, I mean, you've got your scapula that goes all the way around like so. You can follow that all the way around, and that all looks okay. Ribs look good, look good, look good, look good, look good, look good, look good. They all look okay. You follow this clavicle all the way along. Raised a hand. You've raised a hand. Okay. I can try and answer that in a second. You go along like so, and you can suddenly see this completely outlined. This kind of veers off this way and then goes along this way, right? So therefore, this is the problem. I would say that's middle third. And this looks all aligned. The acromioclavicular joint actually looks okay. It's the shaft that looks abnormal. So this may be a situation where you actually got maintenance of the ligaments here, but a fracture of the mid aspect of the clavicle. So it's a distal third. I would say it's probably going to be a middle third, because that's going to be, it's nomenclature at the end of the day, but I would normally split it like this, like that. But you can say distal third, but usually when you say distal third, people are going to, well, radiologists and most people think, oh my God, what's happened here? When you say middle third, you kind of say, yeah, around there. Open fracture, to be honest with you, on x-rays, very difficult to tell because that's your skin. I can't tell what that's gone beyond. Very, very hard. Unless you've got different views, you can really see it sticking out. Personally, when I'm reporting these, I won't even bother. I won't even bother saying open or closed fracture. I just say mid-clavicular fracture with significant malalignment with multiple fragments as well. Yeah, good. Well done. So probably, so what are the abnormalities? Yeah, you guys have said it. Most likely diagnosis can be mid-clavicular fracture, in my opinion. And how do you manage the patient? You know what, for me, the good thing about what I do, I don't know how many of you guys want to be a radiologist, and I'd highly recommend doing radiology. And I'm more than happy to answer a question as to why that's the case later. But the good thing about it is you say, so, okay, look, patient comes into A&E, they've got that fracture. And then the person's got to deal with it. They've got to do all this stuff, and then they've got to call up the orthopod. Orthopod says, yeah, fine, I'll go see them. And then they ultimately may have to do surgery and deal with this patient. Whereas me, I look at the x-ray and I say, fracture, move on to the next one. And I've done the best job I can. I've saved the world by doing that. It's great. I love it. Okay, so abnormalities, yeah, fracture of the mid shaft. Diagnosis is shaft fracture, and you can immobilize a patient, so you can try and put them into a sling, and hopefully that will kind of maybe help align it back in place. Sometimes it can heal itself. Sometimes the orthopods want a CT scan to try and discuss at the trauma meeting to see if they want to do something later on, not straight away. Oh wow, man, time flew. Time really did fly. I'm really sorry. I mean, well, I hope that was all right. So let's say, so yeah, when you are looking at x-rays, you try and use, in the beginning anyway, use the ABC approach, and S, I guess. So A is for alignment, B is for the bones, and C is what was C again, because I don't use that. What was C for you guys? Oh, cartilage. Yeah, cartilage, difficult one, but yeah, fair enough. You can do the cartilage as well if you want to. And then S is for soft tissue. Yeah, try and make sure you got a bank of normal anatomy, or just type in normal shoulder anatomy or normal shoulder whenever you're looking at an x-ray. And what I always think is that the more you see, the better you become at this, right? It genuinely is. And you got to imagine, like, you know, when you're a trainee in radiology, I think you got to, well, it might be more now, but I remember, I think it was like 2,000 x-rays a year you got to go through, and you do that over 5 years. So it's like 10,000 x-rays before you're deemed good enough to be a consultant. And I'm not saying that you guys have to do that number, but it clearly shows that by doing more, there's more likely you'll be able to pick up the abnormality. And after a while, you look at them, and just, the abnormality just feels like it's being thrown in your face because it feels obvious to us. So recognize common pathology. So we went through anterior dislocations, posterior dislocations. You've seen what a fracture looks like in the clavicle. Spoken a little bit about some of the ligaments that exist and what that can look like. And open fractures are going to be more to do with your clinical examination. I think it's going to be very hard to see that on an X-ray. I think, I can't remember the last time I saw an open fracture on an X-ray. But I think, yeah, I mean, sometimes it's so blatantly obvious. I've seen some horrendous motorcycle accidents, and like, you cannot, like, you see the X-ray, there's no way that's not an open fracture, but I don't really comment personally when I'm doing those. But anyway, good. So recommended reading, do check it out. Nice guidelines for shoulder pain and dislocations. Radiopedia is brilliant. I wish Radiopedia existed when I was a young'un. I'm pretty old now, but I still use it to this day. And I feature on some of it, so do check it out. Royal College of Radiology is a great resource. YouTube is great for this kind of stuff. But practice, honestly, practice makes perfect. The more you see, even if it's normal, just have a look, go through the things that we talked about again and again and again. And after a while, it does become second nature. And my dream is always that one of these days, you'll spot something the radiologist doesn't spot, and you go tell them, and it's because something I taught you that may have happened. That'd be awesome.